This conference will now be recorded.
Okay, good afternoon. I'll start the class. Today's topic is intrauterine contraceptive device. So intrauterine contraceptive device, these are materials. They are made up of either plastic or metal or a combination of these materials. And why it is important, because they are very effective in preventing pregnancy, and they are safe, they are convenient, they are reversible, and they are long term. We can use for almost 5 to 10 years depending upon their efficacy. And these does not interfere with the sexual activity. And the next is a device. It is commonly made up of polyethylene, which is impregnated with barium sulfate to render it radio opaque, so that we can see them in scan and x-ray. And the plastic devices, these are flexible, so that they can be straightened and loaded into the introducer and passed through the cervical canal and gently released within the uterine cavity. So these are all the salient features about the IUCD. And this IUCD, each device, it has a nylon thread to its lower end, and this protrudes to the cervical canal and into the vagina, and the patient can feel this, and she can know whether it is in location or it is not. And this is extremely effective. Without using any hormones, this can prevent pregnancy up to more than 97%. So coming to the types of intrauterine contraceptive devices, these are classified into 3 generations, that is first generation, second and third generation. Coming to the first generation, these are inert IUCDs, that is they contain no material like either hormones or any copper or anything else. They are just inert. Example is a Lippis loop, and others like Safety coil and Chinese single coil ring, Mahua ring, Ota ring. These are other types of inert IUCDs. These are not used nowadays, they are abandoned. And the next is the copper releasing IUCDs. Among these, there are various types, various varieties, that is copper 7, copper T200, copper T380, copper T380 AG and SC multi-load. All these are the different varieties in copper releasing IUCDs. And next is the hormone releasing IUCDs. That is, they contain progesterone. Some amount of progesterone will be there, and they'll release daily certain amount of progesterone into the cavity. The progesterones like progestastat, that is levonorgestrel IUCD. This is commonly called as Marina. And the next is the fourth generation, that is a frameless IUCD, that is Fibroplant. This is the frameless levonorgestrel IUCD, and it releases almost 14 micrograms of levonorgestrel daily, and it is under development. Coming to the lifespan of these IUCDs, copper IUCDs, generally they have long lifespan, that is copper T380A, it has a 10 years of lifespan, and 380 AG it has 4 years, and S slim variety it has 2.5 years, whereas hormonal IUCDs, that is progestastat, it has only 1 year of a lifespan, and Marina, it can be used for 5 years. And coming to the types of IUCDs, first one is the inert IUCD. Coming to the mechanism of this inert IUCD, it acts by preventing sperms from fertilizing ovum, so that there will not be any fertilization. And these are the non-medicated IUCD. These acts as a foreign body in the uterus, and they produce a sterile inflammatory reaction in tissue injury, and this acts as spermicidal effect on the sperm, and they prevent sperm from reaching the ova and prevent both intrauterine and ectopic pregnancy. It provokes uterine contractility and increases the tubal peristalsis, so that the fertilization will be delayed. And they require push-out technique for introduction into the cavity. This is the technique of introducing inert IUCD. This is the first IUCD introduced into the National Family Planning Program. So these are the features about inert IUCD. And the next is the copper releasing IUCD. The mechanism of action of these copper IUCDs, they also prevent the fertilization. The copper ions, they bring some enzymatic and metabolic changes in the endometrial tissue, and they produce some biochemical changes in the mucus of the cervix and endometrial secretions, so that fertilization will not occur. And these copper devices, they only act locally, and there will not be any systemic effects, and no changes in the hormone levels will be there. Coming to the ideal candidate for this insertion copper IUCD, the patient should have at least one child, and she should be under monogamous relationship, and there should not be any history of infection or PID. And patients should not who do not want to use hormonal contraceptives, they can go with the IUCD, and for long-term usage also they can go with the IUCDs. And next is the progestin releasing IUCDs. Coming to the mechanism of action of these IUCDs, they cause desetialization with atrophy of the endometrial glands. Therefore, they inhibit implantation. So these are the hormone, this is the progesterone. It leads to atrophy of the endometrial glands. And this progesterone, it also alters the cervical mucus. Therefore, there will be inhibition of sperm penetration and capacitation. And almost 40% of cases, ovulation is also inhibited. There are different types of progesterone IUCDs. Here there are various types, T-shaped and with a bend. All these are the different types of progesterones. And coming to the copper T and progesterone, differences between both of these, copper T IUCD can be used for a duration of 10 years. The lifespan is very long, and whereas progesterone it is only 1 year. And this copper IUCD, it has effective efficacy will be around 99%, and the progesterone it is only 98%. The copper IUCDs, they act on the spermicide and they block egg from implanting, and these releases hormones and it thickens mucus plug, and therefore it prevents implantation. These copper IUCDs, the patient must check the strings before sex and after shedding of the uterine lining, and the same thing is with the progesterone. The next is the Mirena. It is also a third generation hormonal contraceptive. This contains levonorgestrel. It is approved for medical usage since 1990 in Finland, and it is one of the essential medicines in the World Health Organization. Coming to the lifespan of this Mirena, it is almost 5 to 7 years, and the failure rate is very low, that is 0.2%. So coming to the mechanism of action of this IUCD, in Mirena there is levonorgestrel. It is a progesterone receptor agonist, and this Mirena, it contains 52 mg of progesterone, and this releases 20 micrograms per day, and the lifespan will be around 5 years. And the main action is it prevents fertilization. It makes the uterine environmental unfavorable, and it also thickens the cervical mucus, and the endometrial lining will be made thin. So this is the main mechanism of action of the Mirena. So coming to the uses of this Mirena, it helps in the birth control. The main purpose is to control the birth. I mean, it is a main contraceptive. And other non-contraceptive benefits of this Mirena, it helps in heavy menstrual periods, endometriosis, chronic pelvic pain, adenomyosis, fibroids, dysmenorrhea, anemia. In all such conditions, Mirena can be used. This is the main benefits of the Mirena as a non-contraceptive effects. Advantages of Mirena: it is one of the most effective form of birth control, and it can be even used during breastfeeding. And the patient, as we already discussed, this can be used in heavy menstrual bleeding. So patient may have a lighter periods, and this is effective for almost on an average, it is effective for 3 to 7 years. And 90% of users who wish to become pregnant do so within 24 months of removal. So if the patient wants to have a second pregnancy or next pregnancy, then after removal of Mirena, within 2 years she can get a pregnancy. So next is the disadvantages of the Mirena. The patient, sometimes some patients may have a spotting between periods, and they have discomfort, that is cramping pain will be seen, will be there in some patients. In some cases there will be expulsion, perforation, pregnancy, as though pregnancy is rare, but it is less than 0.2%. Instance is less than 0.2%. And infection, ovarian cyst, occurrence of ovarian cyst is more with the Mirena, and mental health changes are also seen in some patients. So these are all the disadvantages of Mirena. And next minor disadvantages will be weight gain. Some patients may complain of weight gain with the progesterone, headache, migraine will be seen, nausea, acne, excessive hairness, and decreased libido. And it also affects glucose tolerance. So these are all side effects of this Mirena. And where all this Mirena is contraindicated means those patients who are already pregnant, in such cases that it is contraindicated. And if the patient is having cervical or uterine cancer, because it will this endometrium with the progesterone, there will it acts, this progesterone acts on the endometrium. So in such cases, the cervical and uterine cancers will not advise a Mirena. And breast cancers, those patients who are having a pelvic inflammatory disease or any STIs, liver disease or tumor and unexplained vaginal bleeding, in all such conditions, this Mirena we will not advise. This is the Mirena. This is the picture. There will be two arms, and there will be a scale and a flange will be there. We have to measure the intrauterine length. That is, uterocervical length should be measured, and this flange should be fixed there. Then this is the slider. After inserting this instrument into the uterine cavity, and after measuring the uterocervical length, we'll fix this flange, and then we'll slide this slider backside so that this IUCD will be in the uterine cavity. The next is how do we place a Mirena? First, we have to visualize the cervix by means of the speculum and cervix and vagina with a suitable antiseptic solution. And then we have to grasp the upper lip of the cervix with holding forceps, and we have to give a gentle traction so that the cervical canal will straighten up. And then the forceps should remain in a position throughout the placement procedure, and a gentle traction should be given. And next, we have to pass the uterus down into the cavity so that we can measure the uterocervical length. After that, if it is too narrow, then dilatation of the canal is recommended under some analgesia. So this is the insertion technique. First, open the sterile pack completely and then use sterile technique and sterile gloves. Push the slider forward. First, we have to push the slider forward in the direction of the arrow to the furthest position to load the Mirena into the insertion tube. If we are pushing the slider forward, then the Mirena will be inside this tube. And next, holding the slider in the furthest position, set the upper edge of the flange. After measuring the uterocervical length, we have to adjust this flange to the respective depth of the uterus. And then, while holding the slider in the furthest position, advance the inserter through the cervix until the flange is approximately 1.5 to 2 centimeters from the uterine cavity. Because this IUCD, it should not touch the fundus, so there should be some gap to the inserter and the fundus of the uterus. So we have to maintain 1.5 to 2 centimeters of gap. And while holding the inserter steady, pull the slider to the mark. So there will be some mark here. There is a mark. This slider it backwards, and we have to wait for 5 to 10 seconds. In the meanwhile, the IUCD flash will be open and it will touch the cavity. And then holding the inserter in place, release Mirena by pulling the slider all the way down. While holding the slider all the way down, gently remove the inserter by pulling it out. So after 5 to 10 seconds, we have to pull the slider further back, and then we have to gently remove the inserter also. And thereafter, we have to cut the strings of the IUCD. Next, removal of the Mirena. It is removed by pulling on the threads with a forceps. So if we want to remove this Mirena afterwards, then we can hold these threads and we can pull this Mirena. This is about the insertion technique. Next is the non-contraceptive uses of the levonorgestrel. Main non-contraceptive uses are it reduces the blood loss. That is, it will help in the management of AUB and anemia. And in patients who are having endometriosis and adenomyosis, it helps in reducing the pain. And fibroids also, the fibroid size will be reduced in those patients who are using the Mirena IUCD. And these do not influence on lactation. There is no influence on lactation or affect infant growth and development when introduced 6 weeks after delivery. The next is the drawbacks. Irregular bleeding, oligomenorrhea. These are common the first 3 to 4 months. And in amenorrhea, some patients have amenorrhea, that is 20 to 50% cases will have amenorrhea for by 1 year, and there will be some difficulty in introduction of the marina. So some patients may need local anesthesia, and some patients will have acne, dizziness, headache, breast tenderness, nausea, vomiting, weight gain, and ovarian functions. These are generally not disturbed, and actually marina, it is too costly. That is, it is almost around 2,500 to 3,000. So coming to the selection of the IUCD, which IUCD we have to use means, copper IUCDs, they are more appropriate, safe, effective with low pregnancy rate than lipis loop. So these are preferred more than a lipis loop. And compared to the old and new copper IUCDs, new copper IUCDs will be more effective and they have a longer duration of use. And then levonorgestrel IUCD, we have appropriate choice for women with pain or bleeding problems. Those who want contraceptive benefits along with non-contraceptive benefits, those patients can go with the levonorgestrel IUCD. And patients who are, if cost factor is an important consideration, then we can go with the copper IUCDs. So coming to the time of insertion, when can we insert this IUCD means, if the patient generally will insert the IUCD after her menstrual cycle, that is immediately after her menstrual cycle, either 5th or 6th day, during or soon after menses, because it avoids the chances of insertion in an early stage of pregnancy, and at that time the cervix will be soft and it is partly dilated, and slight blood loss will be there owing to the fitting procedure, and it will not be noticed by the patient. And the other timing will be the post-abortal. If a patient has a recent abortion, then also we can, after evacuating the uterine cavity, we can introduce the IUCD. So it can be safely introduced during evacuation of the uterus, and no increased incidence of infection or perforation, expulsion, bleeding following insertion after spontaneous or induced abortion, and the patient will have a high acceptance rate immediately after post-abortion. And the next is the postpartum insertion. It has no advantages. The main advantage is there will be ease of insertion and convenience to the user and to the doctor, and particularly of value in India where postnatal care is not satisfactory, and where postpartum care, that is patient will not come for a postpartum checkup. In such cases we can go with a postpartum insertion, and both postpartum and interval insertion after delivery have been found to be safe and effective. And following cesarean section also, immediately during cesarean section we can introduce IUCD, or this can be introduced 1 to 3 months after delivery. So coming to the disadvantages of this immediate postpartum insertion, as the cervix uterus will be very friable, in such cases with insertion of this IUCD, the patient may have uterine perforation and high expulsion rates will be there, and most authorities advocate insertion after 4 to 6 weeks after delivery. It will be the ideal period. Immediate postpartum insertion of IUCD is the best done by means of sponge holding forceps only. Coming to the advantages of this IUCD, the device, it requires only one-time motivation and it does not depend on continuing motivation of the user. So if we introduce, if we counsel the patient regarding IUCD, if we motivate her, then this, depending upon the efficacy, it will last for 5 to 10 years. And this does not require any regular supply, nor there is any problem of disposal or affecting privacy, and they do not interfere with the sexual activity, and the cost is very low. So the patients will accept, except levonorgestrel, which is a very costly IUCD, and no systemic bad side effects will be there, like ossipils, and the return of fertility following its removal is very immediate. It is highly effective, and life risk is very minimal. And coming to the disadvantages, high initial cost, that is, as we already know, from Marina it is almost 2,500 to 3,000, and copper IUCDs, they cost around 350 to 400. So at that time the patient will have a high initial cost, but they're cost effective in long run. And these for insertion, the patient, the doctor should be a trained personnel, and the subsequent treatment should be given. And sometimes the patients may complain of pain during insertion, and some may need general anesthesia or short general, and some cannot tolerate them because of complications like bleeding, pain, vaginal discharge, and mild infection. And some patients, as we know discussed, like in postpartum period, post-abortal period, there will be more chance of infection, and if a patient is having a severe pelvic infection, then she may land up in a PID or any ectopic pregnancy in the future. So she may need an immediate laparotomy, and some cases they have high expulsion rate leading to failure of the contraceptive purpose, and these do not prevent any sexually transmitted diseases like HIV or AIDS. So these are all disadvantages of IUCDs, and no effect on amount and quantity of breast and these can be inserted immediately after childbirth, that is except hormone releasing IUCDs after abortion with no evidence of infection, we can insert them immediately after childbirth. It can be used through menopause, even menopause also we can advise the patients with IUCDs, and no medicines will interact with IUCD, there will be no medicines, and they in some IUCDs, copper IUCDs, they will prevent ectopic pregnancy. So next is the complications. Early and late complications will be seen. Immediately, the doctors will face some difficulty in insertion, and some patients, as we hold the cervix, they will have a massive agar attack, and some patients have a uterine cramps, which leads to expulsion. And early complications of intrauterine contraceptive device expulsion, it is seen in 2 to 5% of patients, and perforation, it is seen in 1 to 2% of patients. Spotting menorrhagia, irregular periods, and bleeding in between the cycles, there will be a to 10%, and some patients will have dysmenorrhea during her cycles. This accounts for 2 to 10%, and vaginal infections and actinomycosis, these are the common infections. And late complications, some patients may have a pelvic inflammatory disease, that is they account for 2 to 5%, and the pregnancy rate, that is a failure rate, it is 1 to 3 per woman years, and ectopic pregnancies will also be seen, and perforation, menorrhagia, and dysmenorrhea, these are the late complications with the IUCDs. This is all about intrauterine contraceptive devices. So far we have discussed what are the types of IUDs, what are the insertion techniques, and then what are the advantages, disadvantages, and what is the mechanism of action, what are the contraindications, and what are the complications. Among this, I think non-contraceptive benefits of IUCD, this is the most important topic for you. This is a question, I think. So this is all about IUCDs. If you are having any doubts, you can ask me. Okay, I'll end the meeting if you're not having any doubts.